Morning. Welcome to Internal Medicine Grand Rounds. It's good to see everyone here this week. We have another wonderful talk today that's not only pertinent to our hematology-oncology colleagues, but also to us as primary care physicians. Our speaker this morning is Dr. Raed Al-Jumaili. He comes to us from the hematology-oncology department, where he joined the faculty last August as an assistant professor. So I guess you can kind of consider this Grand Rounds as his welcome to ECU and internal medicine. Dr. Al-Jumaili had a brief stint in the Northeast before seeing the light and coming to the South. He did his residency training in Philadelphia at Drexel. He did his fellowship training at Tufts Medical Center in Boston. Over the years, he has had the opportunity to be involved in several research projects, including prostate cancer and ovarian cancer. He's spoken on these and also published in these areas. Today he will be speaking with us about lung cancer and the future of lung cancer screening, which is quite a hot topic recently. So please join me in welcoming Dr. Al-Jumaili. Thank you.
So I'll be talking about screening for lung cancer. I'll start with epidemiology of lung cancer, then few points about screening in general, especially screening for cancer, and then we'll talk about screening for lung cancer. So this is the most recent statistics about cancer statistics published just a few weeks ago. So lung cancer is by incidence is the second most common cancer, both men and women, and men after prostate cancer, women after breast cancer, accounting for more than 100,000 new cases in the United States. By mortality, lung cancer is the most common cause of cancer death in both men and women, kind of changing positions with prostate and breast cancer, and accounting for more than 1/4 of all cancer-related deaths in both men and women. So if we look at incidence of lung cancer in men and women, we see that incidence kind of reached a plateau by kind of 90s and started over the past 10 to 12 years. There was decrease in the incidence of lung cancer in men, and experts attribute that to decrease in incidence of smoking. And women, seems like it reached a plateau and started dropping. Mortality statistics shows that lung cancer kind of reached a plateau and end of 90s and started dropping significantly in men, and again experts attribute that to decrease in incidence of smoking and better treatment modalities. In female, it seems again that hit a plateau and started dropping. So this is an important slide, important to remember, because later I'll kind of refer back to that. So this is just the incidence of lung cancer, but this is the localized stage 1 and 2. This is the locally advanced stage 3, and this is the distant metastasis. And unfortunately, more than 50%, more than half of lung cancer is diagnosed in the stage 4 distant metastasis. And if you look at 5-year survival by stage for the localized stage 1 and 2 is more than 50%, for locally advanced about 24%, for distant metastasis less than 5%. This is red, the red is all races, green is white, and blue is African American. It's important to remember this slide because remember the 15%. This is the general statistics, people diagnosed with stage 1 and 2. And this is again important, more than 50% survive more than 5 years. We kind of call them cure, while less than 5% distant metastasis. So I'll go over a few definitions that are kind of useful when we go over the screening studies later. So prevalence screen is basically the first screen that if you take a group of people and you screen them for cancer or anything else, prevalence is the first screen, and incidence screens are the screens that you do later, second and subsequent screens. And in general, you tend to have more positive results with the prevalence screen, and as you do incidence screens, the positives go down. And I'll just go over mainly two biases which are important, especially in lung cancer screening: lead time bias and length bias. So starting with lead time bias is defined as the period of time between detection of the medical condition by screening and when it would be diagnosed due to symptoms. So lead time bias assumes that screening does not change the outcome, does not increase lifespan of the person, and the only thing we do is that we diagnose cancer early, and it seems that we improved the survival of the person, but in reality we didn't do that. Length bias, on the other hand, as we know in all solid tumors, and this is true for lung cancer as well, we have tumors that are low-grade, well-differentiated, and tumors that are high-grade, poorly differentiated. And in general, for tumors that are low-grade, well-differentiated, there's a long time interval between the start of the cancer and when the cancer becomes symptomatic, while in cancers that are rapidly growing, the interval between the start of the cancer and the diagnosis due to symptoms is short. So for length time bias, if you go in one point in time and screen, you are more likely to detect cancers that are slowly growing, well differentiated, than cancers that are fast growing, just because of this time interval. So and it seems that screening improves outcome, but in reality we are just detecting more cancers that are slow growing. And overdiagnosis, this term just means is the extreme form of length bias, and basically means that you detect cancers that would not probably become apparent in the lifetime of the person or affect the life expectancy of that person. So over years, statisticians try to come up with solutions to those two biases. So their solution for lead time bias is to use disease-specific mortality rather than survival. And the reason for that is that in survival, we describe survival as either median survival or 5-year survival. So there is a time incorporated in survival, while disease-specific mortalities is the proportion of people who die from that disease divided by the proportion of people diagnosed with the disease. So there is no time incorporated in it, so to kind of get rid of this lead time bias. And for length bias, is basically the solution is to use randomized studies, because we mentioned this length time bias is due to low-grade and high-grade cancer. So if you randomize people, you're presumably you're getting equal number of risk factors, people with risk factors in the two groups, including low-grade and high-grade cancers. And from that came the notion that if you want to prove that the screening study is useful, you are supposed to do a randomized study with the primary endpoint of disease-specific mortality. So criteria for good screening tests supposed to have good sensitivity and specificity, supposed to have high positive predictive value, and this is important actually for for the board. Whatever board, whether internal medicine or hematology, oncology, they ask statistic questions, and the positive predictive value is the one which is affected by the prevalence of the disease in the community. So if they ask question which one of these variables is affected by the prevalence of the disease in the community, is the positive predictive value. It's not sensitivity, it's not specificity. And again, one other question that they ask all the time is that what I just mentioned is for a screening test, what's supposed to be the primary endpoint, and it's supposed to be disease-specific mortality. It's not survival. It's not anything else. Simplicity, low cost, and safety. This is important specifically because here we are dealing with normal people, supposedly people who are not sick, so we don't want to harm them. And acceptable for patient and clinician. Availability of effective intervention is very important because if we don't have effective intervention, there's no point of detecting the disease early. So going to screening for lung cancer specifically, the first study which was done to screen for lung cancer was done in the United Kingdom, Northwest London Mass Radiography Service, and in this study they took little more than 55,000 individuals. It was this study actually by Britt et al. Published in the journal Thorax in 1968. So they took 55,000 and a bit individuals. They were all male, more than 40-year-old, and 88% of them were smokers. And they took them and they randomized them into chest x-ray every 6 months for 3 years, or chest x-ray at baseline and at the end of these 3 years. And if you look at the lung cancer mortality, 0.28%, and the screened group 0.27%, and the control group, and there was no difference in that. The first study done to screen for lung cancer in North America, and it's an important study that affected actually the policies for screening, was the Mayo Lung Project, and was done from November 71 till July 76. They took more than 10,000 male smokers, and they did a prevalence screen with chest x-ray and sputum cytology, and then they basically took out the people who tested positive. They took people who tested negative, have life expectancy of 5 years, good respiratory reserve that allow lobectomy, and invited them to participate. They randomized them into 2 arms. The intervention arm had a chest x-ray and sputum cytology every 4 months for 6 years. I remember this number, 75% actually were compliant with that. The usual care arm, they were advised to have a chest x-ray and sputum cytology, and 78% of them had at least 1 chest x-ray. And the reason for that the control arm were advised to do chest x-rays and sputum cytologies at that time. In Mayo Clinic, everybody was used to be advised to have a chest x-ray and sputum cytology. This was their policy at that time. So that's why they used that for the control arm. And they followed individuals for 9 years. The lung cancer mortality, which is, this is the primary endpoint used, was 3.2% per 1,000 person year, and the intervention arm 3 per 1,000 person year in the usual care arm. So there was actually more lung cancer mortality in the intervention arm, a little bit, not statistically significant. So there was more lung cancer mortality, but there was improved in 5-year and 9-year survival in the intervention arm. And a greater proportion of people in the intervention arm were diagnosed with low-stage cancer. So this was published, the initial result was published in 1986. And since then, many people tried to come with a reason why there was slightly increase in lung cancer mortality, while there was there was increase in survival, increase in mortality, and more. Although we diagnosed more cancers at early stage, there was no reduction in lung cancer mortality. So in 2000, Marcus and colleagues published 20-year follow-up of the Mayo Lung Project, and as you can see in this graph, this held. So there was still increased death from lung cancer in the intervention arm compared to the usual care arm. So if you look at that, 337 deaths from lung cancer in the intervention arm, 303, 4.4 per 1,000 person year in the intervention arm, 3.9 per 1,000 person year in the usual care arm. And even for all-cause mortality, there was slightly more deaths in the intervention arm than in the usual care arm. And again, survival data held true. So again, we have this discrepancy where there was better survival, but more lung cancer mortality. And if you look at that, median survival just by lung cancer, 1.3 years versus 0.9 years, and all causes 1.2 versus 0.7. 5-year survival just by lung cancer, 35 versus 19, all cause 26 versus 11, so better survival and more lung cancer mortality, and it was actually statistically significant. So in this publication, they tried to come with an explanation why is that, why there is improved survival, but still there's more lung cancer mortality in the intervention arm. So they mentioned population heterogeneity, and what that means, what that statisticians kind of refer to is failure of randomization. So when we randomize people, we assume that we are creating equal arms in terms of risk factors, but what if this is not right? Contamination is what I mentioned earlier, is that 75% of the people in the intervention arm were compliant, while 78% of people in the control arm had at least one chest X-ray. What if this affected the result? Misclassification of lung cancer as underlying cause of death, and what this means is, in this study, they went back and looked at death certificates, and they had actually an expert panel who kind of looked at the causes of death. But they're mentioning why if, you know, what if they did not, like they assume that this is, you know, this was not true. Like they mentioned lung cancer as the cause of death, but was not. And overdiagnosis is what I mentioned earlier, the extreme form of length bias. So my mentor at Tufts Medical Center, Dr. Gary Strauss, he's someone who published a lot in the field of screening for lung cancer. He published in JCO back in 2002, I thought, a good analysis of the Mayo Lung Project. And he tried to take lead time bias and length bias and kind of analyze both of them and come up with a conclusion that they are not the reason for this discrepancy between survival and lung cancer mortality. So for lead time bias, as we mentioned earlier, it is the difference between the time interval where the disease or the cancer is diagnosed by screening and the time where it's diagnosed due to symptoms. So this is the graph for that from the time of diagnosis till and then you start generating the graph for survival from the time of diagnosis. So what he did the same analysis, but not from the time of diagnosis, but from the time of randomization. And even from the time of randomization, this difference in survival held true. So his conclusion was that, okay, it's not from the time of diagnosis, so this survival advantage is real. For length bias, as we know, length bias is the outcome due to we are detecting more cancers that are slow growing, and that's why we have better survival. So what he did, he took all screen detected cancers and all symptom detected cancers and generated a graph for that, and he said this is length bias, while this is the graph based on randomization. And we mentioned earlier that the way to get rid of length bias is to do randomization. So he said, so this is a real survival advantage. It is not due to bias. So the other study, which is a big study, is still going on in the United States, is the PLCO trial, and that used, again, chest X-ray as screening. And PLCO stands for prostate, lung, colon, and ovary, and basically it screens for all 4 cancers. And the Journal of the National Cancer Institute in 2005, they published the prevalence screen for lung cancer. So what they did in this study, they took healthy people, and this is a difference. I'll come in a minute. This is a difference between this study and all other studies done to screen for lung cancer. Is that these are supposed to be healthy individuals, not high-risk people. So 55 to 74 year year old and with no history of these 4 cancers. So they took 154,000 individuals, randomized them into screening group and control group, and the screening group, they got prevalence screen for just by doing a chest X-ray prevalence screen for lung cancer. And so the difference regarding lung cancer between this and all other studies, first, it included men and women equal numbers. Participants were normal, not high-risk individuals. There was no prevalence screen for the control arm. So all other studies, they kind of tested screen versus another type of screen, while this one was screen versus no screen. And then the control subjects got no screen, as I mentioned. So this is the result of the prevalence screen. Again, just chest X-ray. And 8.9% of all chest X-rays were considered positive. If you look at that, the possibility of positive results was higher in older people, less in younger people. And then if you look at that, never smokers, 8% had positive X-rays, and former smokers, 95% had positive X-rays, and current smokers, 11% had positive X-rays. This is kind of a little 8% never smokers had positive X-ray. This is much higher than what would be expected. But even though, when I'll show that in the next slide, very few percentage of those never smokers actually had lung cancer. So this is important. I'll refer back to the slide that I mentioned earlier. If you look at the lung cancers detected in this prevalence screen, so if you look at the percentage, and this is stage 1 and 2, so more than 50%, more than 60% actually had stage 1 and 2 lung cancer. If you remember the slide that I mentioned earlier, for the general population, just about 15% are diagnosed with stage 1 and 2 lung cancer. So we are detecting more cancers in early stage. And if you look at this, so I mentioned 8% for never smokers, 8% had positive X-rays, but just 0.4% per 1,000 screens had actually lung cancer. While in former smokers, 9.5% had positive screen, but 2.4 per 1,000 screens had lung cancer. For current smokers, 11% had positive X-rays, and 6.3 per 1,000 screens had lung cancer. So significantly, we are detecting significantly more lung cancers in smokers and current and former smokers that would be expected. So Hawkins et al. Published in 2010 so this the PLCO, what they did a prevalence screen, then they did 3 more screens. So the previous publication was just the prevalence screen. This is a publication for all 4 screens, and this study is actually still ongoing, and with lung cancer mortality as the outcome. So for all screens, 7.5% had positive X-rays, and as we mentioned earlier, the kind of prevalence screen highest positivity. As you go down, less positivity. Again, older people, more positive test, and current smokers more than former smokers, more than never smokers. And actually, if you look at people's history of family history of lung cancer, more people had positive X-rays than people who didn't have family history. Still, we don't consider family history as an important risk factor for lung cancer, but many experts actually in the field think that it is actually an important risk factor. So if we look at the type of lung cancer and stages, so if you look at this column here, so non-small cell lung cancer, we are detecting more non-small cell lung cancer than small cell lung cancer with screening, that's kind of the trend. When you do screening, you detect more non-small cell lung cancer and you detect more adenocarcinoma. So this is the general statistics for the general population. In general, it's about 87 to 85% non-small cell lung cancer, 13 to 15% small cell lung cancer. So with screening, you detect more non-small cell lung cancer. This is the types of cancers detected with interval, interval lung cancers means cancers detected between screenings, and this is never screened. And you see you're detecting more. We detect more non-small cell lung cancer with screening and more adenocarcinoma with screening. And if you look at the stages, again, the same thing holds true here, about 60% stage 1. Stage 1 and 2, while significantly more with screening than with interval and never screened. So all of that was screening using chest X-ray. So how about screening using CT scan? And back in 2006 in New England Journal of Medicine, the ILCAP study was published, and ILCAP stands for International Early Lung Cancer Action Project. And this was not a randomized study. This was a study where just a cohort study. They took more than 31,000 asymptomatic person, again at high risk for lung cancer, and they underwent baseline and annual low-dose CT scanning from 1993 to 2005. This was an international study done in Japan, United States, Europe, Israel, and China. And high risk defined in this study as either smokers, former smokers, second-hand exposure to smoking, or people who had exposure to occupational exposure to carcinogens. Carcinogens for lung cancer. And they did, and I think this is kind of useful guideline if we do screening using CT scan, or we just started in our institution here SPIN clinics, pulmonary indeterminate nodule clinic. What should we do with those nodules? I think this is a kind of useful guide. These are the nodules that we see when we do a CT scan for something else. So for what they did for the baseline screen, it was considered positive if they detect a solid non-calcified nodule more than 5 millimeter, or non-solid non-calcified nodule of more than 8 millimeters, these kind of like shadows, and then or a solid endobronchial nodule. And if this is detected for nodules that are 5 to 14 millimeter, they either repeated CT scan in 3 months or they got a PET scan immediately. If the PET scan is positive, then they advised biopsy. For nodules that are more than 15 millimeter, they kind of offered biopsy, and if the patient refused, they offered these two options. For annual screening was considered positive if a new nodule is detected, and then what should we do with that? If that nodule is more than 5 millimeter, they offered a course of antibiotic and repeat scan in 1 month. If the nodule was 3 to 5 millimeter, they repeated scans in 3 to 6 months. So they took those more than 31,000 asymptomatic individuals, and this is the baseline CT scan. The 4,186 were positive, and out of that, they detected 405 lung cancers. With the subsequent screens, 1,460 scans were positive, and out of that, 74 lung cancers were detected. And if you sum this and this, you get to 484 lung cancers, and out of that, significant proportion was stage 1 lung cancer. So 13% of individuals had underwent baseline the prevalence CT scanning, and 5% who underwent annual CT had positive results. Biopsy was performed in 535, and 492 cancers were detected. Out of that, 479 was lung cancer. So, and this is the baseline prevalence screen. So 1.3, kind of like the average of that, more in older people. 1.3 had positive results. 0.3 in the subsequent screens were diagnosed with lung cancer. And the 10-year survival for all groups was 80%. 85% had stage 1, and the 10-year survival for people who had stage 1 was 88%. And people who actually had an X-ray, their 10-year survival was 92%. Very, very good results. So these good results with low-dose CT screening encouraged the NCI to sponsor this study published back in August 2011, New England Journal of Medicine. So I will go over more details regarding this study. So the rationale for doing the study is that 94 million current and former smokers in the United States remain at high risk for lung cancer. And remember, although the incidence of smoking is decreasing in the United States, still more than 20% of the population smoke. And it's actually the incidence of smoking is increasing in other parts of the world, for example, in Southeast Asia. And they mentioned that randomized studies using chest X-ray sputum cytology failed to detect reduction in lung cancer mortality, this magic endpoint. And they mentioned that observational studies, as I just mentioned, the IL-CAP, showed good results using low-dose CT screening. So that's why the NCI sponsored this study. And this was a study, as I'll mention in a minute, was basically comparing CT screening to chest X-ray screening, not CT screening to no screening. And their rationale for using chest X-ray screening as the control group and not just doing nothing is that the PLCO was an ongoing study, and still is actually an ongoing study at that time. And they thought if the PLCO, the results a positive result, then the chest X-ray will become kind of chest X-ray screening will become the standard of care. And then if they do CT versus no screening, then their results will be not relevant. So that's why they chose, basically, that's what they mentioned. That's why they chose chest X-ray for the control group. And the participants were, this study was done from August 2002 till April 2004, and then the screening took place up till 2007, and then they followed people up till 2009. Their inclusion criteria was age 55 to 74, more than 30-pack year history of smoking, and for former smokers or people who quit should be within 15 years, not more than 15 years. Their exclusion criteria was previous diagnosis of lung cancer, CT scan within 18 months, history of hemoptysis, or significant weight loss. So they enrolled more than 53,000 people, 26,000 were randomized to low-dose CT screening, 26,000 to chest X-ray, and the patients, or people, I should say, were invited to undergo 3 screenings. So this was T0, T1, and T2 at 1-year interval, and either CT scan or chest X-ray. And they mention here that what was considered as death from lung cancer is everything, including if someone died from intervention study or someone died after treatment. So all of that was considered as death from lung cancer. Primary endpoint is the lung cancer mortality, as we mentioned, and secondary endpoint was incidence of lung cancer, rate of death from any cause. Intention to treat principle, and this means basically that if you randomize people to one arm and the other, you just they are in that arm, and then you take it from there. You don't basically you just take them by the randomization. And they had a safety data and safety monitoring board who met every 6 months, and in October 2010 they decided that they got results that are significant and decided to publish their data. So if we look at demographics for the 2 groups, they are identical. They followed a median duration of follow-up was 6.5 years, and actually compliance with CT and chest X-ray was very, very good, 95% in CT, 93% of chest in the chest X-ray group. So compliance was very good. If we look at this table, most people were 55 to 65 years of age. 60% were male, 90% were white, and about 50% current and former smokers. Remember one thing, most people who are diagnosed with lung cancer nowadays are former smokers, actually not current smokers, not most, but more former smokers than current smokers. So people who quit smoking still remain at high risk for lung cancer. So looking at the results here, if we look at the positive result, and so 27% in the CT group versus 9.2% in the chest X-ray group. So more positive results in the CT group than chest X-ray group. And then what's again is important here to mention is that more than 95%, more than 95% the CT group was false positive, and about 95% of the positive chest X-ray were false positive. So significant false positives in both CT scan and a chest X-ray. So what's kind of interesting here, and I don't have a clear explanation for that, but it's a good thing, is that if you look at the complication rate, so first the rate of complication in both people who had positive CT scan or chest X-ray was low in general, 1.4, 1.6%, and in people who actually had no cancer, the rate of complication was very low, 0.06%, and the CT scan 0.02% in the chest X-ray group. Significantly more complications in the people who actually had cancer, and this is good because if someone has no disease, you don't want to harm them. So 1,060 lung cancers were diagnosed in the CT group. 941 lung cancers were diagnosed in the chest X-ray group. So more lung cancers were diagnosed in the CT scan. This is good, not bad. You want to detect more cancers in the screen group than the control group. This is just the breakup of this, and 649 diagnosed after a positive test, 44 after a negative test, and 367 after. And what that means, negative test and no test. Negative test is in between screening, and no test is either people who didn't have any screen, or people who had cancer after they finished those 3 screens. The corresponding numbers for chest X-ray was 279, 137, and 525. And again, this held true is that in each group, percentage of stage 1 lung cancer, early lung cancer, was significantly more in the screened group than in the control group. If you look at that, 60% versus 20%. So how about lung cancer mortality? So 356 deaths from lung cancer happened in the CT group, 443% in the chest X-ray group, corresponding to a rate of death from lung cancer of 247 per 100,000 person a year in the CT scan group versus 309 deaths per 100,000 person a year in the chest X-ray group. And there was, with a hazard ratio of 0.80, and there was a risk reduction using CT scan of 20%. Remember, always risk reduction is the hazard ratio, 100 minus hazard ratio. And if you look at the graphs, this is just the lung cancer, the incidence of lung cancer. There was significantly more lung cancer detected in the CT scan group than chest X-ray group. While if you look at the mortality, there was less lung cancer mortality in the CT scan group than in the chest X-ray group. And interestingly, there was actually decreased death from all causes in the CT scan group than in the chest X-ray group, which was statistically significant as well. So in their discussion section in this study, they mentioned several limitations or some problems that can happen with CT screening. First, the limitation. They mentioned the healthy volunteer effect. These are people who are invited to participate. So, people who participate are probably the people who are motivated, healthy. So, does that apply for general population? They mentioned that this was done a few years ago. The quality of the scans are probably better now, and this will likely increase the false positives and probably more complications. And then they mentioned that the NLST this study was done in big institutions. So does that, if you start doing that in the general population, are we going to get the same results? And then some other things they mentioned is the high false positive rate, about more than 95%, and possible harmful effect from radiation, which people worry about. And I thought this is an interesting part of the discussion that I put here. They mentioned a few thoughts. Are less frequent screening equally effective? Do we need to do that every year? How long we should continue to screen? Should we use those 5 millimeters? Should we increase our cutoff to reduce the false positives? And then I think to their credit, I think this is very humble to mention. They mentioned although some agencies and organizations are contemplating the establishment of lung cancer screening recommendation on the basis of the finding of NLST, the current NLST data alone are, in our opinion, insufficient to fully inform such important decision. I thought this is very humble because other people who would have done the study would have said, we have the magic thing, let's do it. And sure enough, the NCCN, which is our big organization, National Comprehensive Cancer Network, and everybody goes to their recommendation, they just a few weeks ago changed their recommendation, and now they actually recommend to screen for lung cancer. And if you look here, they say high-risk individuals, exactly this. They exactly had the people, the inclusion criteria for the NLST. 55 to 74, more than 30-year history of smoking, smoking cessation less than 15 years, category 1, they're recommending low-dose CT screening. And what category 1 means is that it is supported by randomized controlled trial. So they are recommending that. This is my last slide. Any questions?